Good morning. This week we have a very nice week, and we have been visited by Dr. Ann Gillenwater from MD Anderson Cancer Center and Dr. Rebecca Richards-Kortum. She's a professor and the chair of the Department of Bioengineering at Rice University, and she and her group has been developing a lot of optical technologies for diagnostics of cancer, and also producing some technologies for diagnostic tests of infectious disease, which is a very interesting topic, especially for countries like Brazil. And today, Dr. Kortum is going to show us some results of this technology that they have been developing there at Rice University. And I'm going to ask to keep the questions to the end of the seminar, and I hope you'll all enjoy.
I'm going to give a short seminar this morning because this is a new project for our lab. As Christina said, our lab has mostly worked in the area of early detection of cancer, and we had a chance to talk about that yesterday. And one of the things that we realized over the last year is that some of the same technologies that we were developing for early cancer diagnostics might also have application for the point-of-care detection of infectious disease. And so over the last year, we've been doing some proof-of-concept experiments to think about whether or not it would make sense to pursue developing point-of-care diagnostics using these approaches. And essentially what we're trying to do is to leverage advances both in nanotechnology as well as advances in microfabrication of optical sensors to be able to produce low cost but very sensitive diagnostic techniques to look at infectious diseases. And this is a collaboration between my lab at Rice and between Clint White's program at the UT Medical Branch in Galveston. And so what I was going to talk about this morning is to talk just first of all about the goals of the research project, because they really are what drove the design criteria for the sensors that we want to develop. And then I'm going to talk with you about the approach that we're taking, where we're trying to use targeted nanoparticles to assist in the detection of these pathogens, and then use microfabricated optical sensors to be able to detect whether or not they are in fact present. And I'm only going to be able to show some preliminary results because, as I said, this is a project that we started about a year ago. But just to give you some context, we are located at Rice University, and Rice is just across the street from the Texas Medical Center. And as I said, really the core mission of our lab previously was to look at early detection of cancer. And as part of that, we put a really big emphasis on putting our graduate students in the clinic, where they were seeing the challenges that physicians face when they're taking care of their patients. And as they were developing the instrumentation for their clinical trials, they were doing this very much in collaboration with physicians. But as we began to think about diagnostic tests that would have application in developing countries, we really tried to take an approach where we built collaborations with medical facilities located in developing countries. I began an educational program with several countries in Southern Africa, again about a year and a half ago is when this started. And so as part of that project, we had an opportunity to visit 4 countries in sub-Saharan Africa: Malawi, Botswana, Swaziland, and Lesotho. And I'm just going to show some photos that I took on that trip, because it really shaped our thinking about what infrastructure would be in place to utilize these point-of-care diagnostic technologies, and how inexpensive and how sensitive did they need to be. And so I'm starting with some photos from Malawi. In Malawi, we saw very few cars. Most people travel by foot or by bicycle. And we had an opportunity in Lilongwe to visit the government hospital. The government hospital did not have any laundry facilities at all, so patients got their baths outdoors. This is a pediatric patient at the hospital, and their moms had to do all of the laundry outside in that same area. And this photo was taken in the pediatric ward in the government hospital. There were about 80 beds there, and there were about 200 children who were admitted in the pediatric ward. So every bed had more than one child, and the ratio of nursing staff to patients was about 80 to 1. And so patients couldn't be admitted to that hospital essentially without having a parent or a guardian who could stay there with them all the time and provide their day-to-day care. And so mostly this was moms, and the moms were sleeping on the floor next to the bed that their child was in. So it was a place with very, very limited resources. Botswana, by African standards, is a fairly wealthy country. It has the second highest per capita income on the African continent. This is a photo of the main government hospital in Gaborone, Botswana, Princess Marina Hospital. And there was much more infrastructure in place in Botswana. For example, they did have the capability to do CT exams at this hospital. But a lot of the equipment, when we were there, we found was not functioning, either because the equipment was broken or because consumable reagents that were necessary were just not available because everything had to be imported. And during the 3 months prior to our visit, one of the physicians that we interacted with told us that in that 3 months they had run out of spoons to feed the patients with in the pediatric ward, slides for making diagnostic samples, reagents for blood chemistry, reagents to do CD4 counts, which in a country with a very high HIV prevalence is a huge issue. And they were not able to test HIV viral load as well, and the list goes on and on. Princess Marina Hospital is located right across the street from the University of Botswana, but there is very little collaboration actually between researchers in the university and physicians in the hospital. This photo was taken at a government hospital in Swaziland. This was the diagnostic lab, the main diagnostic lab for the hospital. And what we observed here was pretty common for the hospitals that we visited, which was that in these labs, there tended to be a lot of personnel who had good training, but very, very little equipment that was actually functioning. And there tended to be, the power would fluctuate throughout the day, it would go on and off, and they might or might not have running water. This was also taken at the government hospital in Swaziland, and this is a CT imaging system and an elevator. And in fact, they're both broken, and they were unable to get parts to repair them, so they were using the CT machine to block the entrance to the elevator. Swaziland, it's a country of about 1 million people. It's just been devastated by AIDS. The life expectancy today in Swaziland is just over 32 years, and the HIV prevalence rate among adults is 42%. And in a country of 1 million people, there are 70,000 children who have lost both of their parents to AIDS. So, as a result of this visit, we came back and thought very much about what would be the design criteria that a new point-of-care diagnostic would need to satisfy in order to be useful. And so in most of these countries, the per capita health expenditures were less than $20 a year. So clearly, we had to have something that was very cost-effective. And we had to have something that did not require electricity, did not require significant expertise to be able to implement, and ideally also would not require consumable reagents, because we saw over and over again that when consumable reagents were unavailable, the test was just unavailable. And we were particularly excited because at Rice, there is a group that we collaborate with quite closely, led by Professor Tomas Tkaczyk, who is very interested in using microfabrication techniques to make tiny optical devices. And I'll talk more about this later, but this right here essentially is a fluorescence microscope that can run with an LED and a CMOS image sensor. And you can see it's very small. It can run on a 3-volt watch battery. And we estimate that you can make these readers, which could be used over and over again, for around $10. In our lab, we had developed some expertise in targeted nanoparticles, And we were currently targeting them to label tumor cells, but we were very interested in maybe thinking about using them to label pathogens instead. And we thought by combining these two approaches that potentially we would add something of benefit. I'm going to skip through that and move right on to the point of care diagnostics. So the concept is just that you would take some type of in vitro specimen. So you might take some saliva, you might take a small drop of blood, you might take a stool specimen, and then you would develop a microfluidic sample chamber, and then you could mix your input specimen with your targeted nanoparticles. And we could do that inside a microfluidic chamber that could either be disposable or could be reusable. And then what we could do is we could either, using the microfabricated optical sensors of our labeled specimen, or we could measure, we can use the same technology to make tiny little and measure the spectrum of that labeled sample. And then we could automate the analysis of that so that you either got a yes-no result or you got a semi-quantitative result. And so that's the concept. And what I'm going to talk about today is some preliminary results using Cryptosporidium detection, which is a pathogen that's responsible for diarrhea. Some preliminary results using the detection of the human papilloma virus, which is responsible for virtually all cervical cancers throughout the world. And then talk about some back of the envelope calculations that we've done to look at the level of detection of malaria that might be possible using this technology. There was a recent review article that was published. The study was supported by the Bill and Melinda Gates Foundation that looked at what would be the impact of improved diagnostic technologies that could be implemented at the point of care in the types of laboratories that I showed you pictures of. And you can see that for a variety of infectious diseases, lower respiratory infections, tuberculosis, HIV/AIDS, diarrheal diseases, in all of those cases, there is huge potential to improve the quality of healthcare and to reduce mortality and morbidity if you have better access to point-of-care diagnostic technologies. So the current approaches to point-of-care detection of infectious disease, if you take the example of malaria, for example, typically what's done is you take a drop of blood. You would either prepare a thick smear of blood or a thin smear of blood. You would stain it with a Giemsa stain, and then a cytotechnologist would examine that under the microscope. And it's actually very, very challenging to recognize the parasite and to quantify the level of parasitemia. It takes a lot of training to be able to do that. The advantage is that all you need is a white light microscope and a relatively inexpensive stain, the Giemsa stain. So that's one approach. Another approach is to do the Immuno chromatographic strip test. These are like the home pregnancy tests where you put a drop of urine or you put a drop of blood on a nitrocellulose membrane, and then that would travel past, capture antibodies, and you would use either labeled liposomes or gold particles to make the color change if your pathogen is present. And there are some good rapid diagnostic tests for malaria. For example, there are some immunochromatographic strips that are available for a few dollars a test. Many of them use capture antibodies that are temperature sensitive, and that's one of the limitations of that technology. And then really the gold standard is polymerase chain reaction, or PCR, which is the most sensitive test, but is virtually unavailable in sub-Saharan Africa, for example. In Malawi, there's one lab in the country that does PCR, and it's done for research purposes. So our approach then was to try and leverage some of the technology that we had developed with nanoparticles, and to take our nanoparticles or to take fluorescent dyes and conjugate them to molecular markers that would bind to the pathogens of interest. And we've taken two approaches, either to target proteins associated with the pathogen or to target the nucleic acids associated with the pathogen. And I'll talk about both of those. We originally thought that the protein targeting approach would be the easiest. And in fact, what we found is that the nucleic acid targeting approach turned out to be both much simpler and much more versatile in terms of being able then to take the advances that you made from one pathogen and translate them to another. And then, as I said, to use microfabrication technology either to do microscopic imaging or to do spectroscopic analysis for the detection and quantification. And so the idea is, let's say you're taking a specimen that might be blood, that might be stool. So if it's blood, you might have white blood cells, you might have red blood cells, and you might have the pathogen of interest. And we can put size selective membranes in place here. So we might have one membrane that has a pore size of 10 microns, another membrane that has a pore size of 1 micron, and then we can do some size selective separation of our specimen and then place our miniature microscope on the other side. So in the case of Cryptosporidium, which is about a micron in diameter, this is an ideal way to separate out the pathogen from the white blood cells and the red blood cells. In the case of doing CD4 monitoring, it's a great way to separate out the white blood cells, and then you can stain them for the CD4 receptor. And then, as I mentioned, we're very interested in using the miniature microscope technology so that you could couple your microfluidic sample chamber to the type of tiny microscope which could sit down here or could sit up here and image the component of the sample that you're interested in taking a look at. So let me tell you first about the approach using the protein targeting. So in this approach, we have a microorganism, and it has some protein target on its surface. And so what we want to do is we want to take an optically active moiety. That could be an organic fluorescent dye, that could be a metal nanoparticle, it could be a quantum dot. And we're going to conjugate that to a binding molecule that will bind to our protein target on the microorganism. So now here's our labeled microorganism, and there are a variety of targeting molecules that we can choose. We can choose monoclonal antibodies and conjugate them to organic fluorescent dyes, or we could take semiconductor nanocrystals and also conjugate them to antibodies that would bind the protein target, or we could choose gold nanoparticles that we target either with aptamers or with monoclonal antibodies. And I'm going to show you results for Cryptosporidium, where we have targeted both with antibodies using either a quantum dot as the label or an organic fluorescent dye as the label. And one of the wonderful things about in vitro diagnostics is you don't have to worry at all about the toxicity of the dye that you're using, because you've taken the sample outside the body, and so you're free to use things like quantum dots where the toxicity might be a big concern for in vivo applications. Let's see, I think a slide got out of order here. So the other approach, in contrast to protein targeting, is to do nucleic acid targeting. And so the approach that we're taking for nucleic acid targeting is to use the gold nanoparticles that I talked about yesterday, and to measure the change in the surface plasmon resonance when you have gold nanoparticles that are closely aggregated. And we're going to use our pathogen as the way to cause the aggregation of the gold nanoparticles. So in this approach, what we've done is we've taken gold nanoparticles and we've conjugated a spacer to them. And then to that spacer, we conjugate a short oligonucleotide. It's maybe 15 or 20 base pairs long. And we choose that oligonucleotide to be complementary to a portion of the nucleic acid associated with our pathogen. Particles that have two different sequences, and we choose those sequences so that they are close together on the target DNA or RNA of our pathogen. And so if our pathogen is present, then we're going to get the binding of both oligoprobe 1 and oligoprobe 2, and so the target will induce the aggregation of these nanoparticles. And as a result, we can see the shift in the plasmon resonance. And as an example of what we can do if we do dynamic light scattering, and we have just a population of the gold nanoparticles in solution with no target present, we chose 50 nanometer diameter gold nanoparticles, and now we've conjugated them to our oligo and our spacer. And you can see that the mean size of our particles is 56 nanometers in the absence of any target. So now if I take my same solution and I add 1 picomole of my target DNA. Then you do the same dynamic light scattering. What you find now is that the average particle size is 800 nanometers. And that consists of about 3,000 particles aggregated together, because essentially you're going to get a whole array of these nanoparticles that are cross-linked together by the presence of the target nucleic acid that you're looking for. And it's very easy to see the shift in the plasmon resonance as you go from something that's 56 nanometers to something that is 800 nanometers.
What is the order of magnitude of this shift?
The order of magnitude, you'll see some data that I present later. It's about 150 nanometers, and you can see it go from green to orange. You can see it with your eye. So the first example where we have some initial data is the example of Cryptosporidium. So Cryptosporidium is a parasite that's responsible for a lot of diarrheal disease. And in many developing countries, particularly in sub-Saharan Africa, diarrheal diseases in children are a large cause of morbidity and mortality. In fact, they're the second cause of morbidity and mortality among children in developing countries. Diarrheal disease can be caused by viruses, bacteria, and parasites. Cryptosporidium is an important parasite, which is a cause of diarrhea. For example, in the US, people are concerned about Cryptosporidium more because of concerns about bioterrorism. It's actually classified as a bioterrorist threat. There was a famous outbreak in Milwaukee in the US where in 1993, by accident, the water supply in Milwaukee became contaminated with Cryptosporidium. And as a result of that, over 400,000 people became ill. Many, many people were hospitalized, more than 100 people died. And because it's difficult to detect Cryptosporidium, it wasn't detected for quite some time. People didn't realize what was the cause of this outbreak. There was a recent study, 2 studies in Brazil. Cryptosporidium was found in 19% of children who had diarrhea. This was done using immunofluorescence techniques. Using PCR, there was a study in an urban slum in Brazil, and more than a third of the children had Cryptosporidium in that study. So it's a very important cause of diarrhea throughout the world. So one approach is to use immunofluorescence, so we can take an antibody that will bind to the surface of the parasite. We can conjugate a fluorescent dye or a quantum dot to that antibody. And here's some data that we took in our lab. Here's the Cryptosporidium. These are about a micron across. And so the data shown here in A were obtained with just a commercial laser scanning confocal microscope. And so you can easily see the Cryptosporidium that's present there. If instead of using a organic fluorescent dye, we use a quantum dot, you can see here we can target it with a quantum dot as well. Now, of course, one of the problems with doing immunofluorescence is that you don't find laser scanning confocal microscopes in the types of labs where you really need to be detecting Cryptosporidium. If you use a non-confocal, so this is just a standard fluorescence microscope, these were done with 63x objective oil immersion. This was done with a 40x air immersion objective. And so you can see it's a little bit more challenging with just a standard fluorescence microscope to see the labeled pathogen. And so in collaboration now with Tomas Tkaczyk at Rice, what we've been exploring is whether or not we can use these tiny microfabricated fluorescence microscopes as a way to bring fluorescence microscopy to places that don't currently have it. And so the original concept for this was that you could take a silicon wafer and you could essentially build a microscopic optical table that might be, say, 3 millimeters by 7 millimeters across. And you could position on that micro-optical table all of the elements that would be part of your fluorescence microscope. So I'm going to show you some results going back to the very first micro-optical table. So at the time this project was begun, which was about 7 years ago, what we were doing was taking these silicon wafers and using deep reactive ion etching basically to etch these slots that had little springs at the back of them. And so you could snap your optical elements in place in those little slots. And then we used grayscale photolithography to print the tiny lenses that would be part of this, and you could print both the lens and the mounting feature that would lock into place behind this spring, so that you had essentially a zero alignment design, because your ability to print was much greater than the alignment tolerances that your optical design called for. So you could just snap it into place and it would automatically be aligned. And so here is one of those first microscopes with the lenses being snapped into place. And then this is just a 2 millimeter diameter lens that was obtained from Edmund Scientific, cemented into place. Here's the very first microscope that we assembled in our lab. The illumination at the time was provided by a fiber. Here was our resolution target. Here's the folding mirror, the lenses of the objective. And we were using a big camera, which is back here. And so here's the group 6 elements of the Air Force resolution target. You can see you can get quite nice resolution with this device. And this was imaging cells now in transillumination mode. And you'll notice that the cells in the center of the field are nicely in focus, whereas the cells at the periphery of the field are not so nicely in focus. And that's because actually the image plane of this device is curved. Now, we didn't worry about that at the time, because at the time this was being developed to do tissue imaging. And in tissue imaging, it's not a problem if your field of view is a little bit curved. If you're imaging cells on a slide, which is flat, it is a problem. And so we've now begun to look at designing for a flat field device. Here was the next generation device. You can see the folding mirror has been miniaturized and put in place on the device. And then we moved away actually from doing the deep reactive ion etching to doing X-ray lithography in metal, because it was much more cost effective to build the platform of the microscope objective using the X-ray lithography in metal. And so here's one of the lenses that's been printed using the grayscale photolithography. And then here are 3 lenses that are snapped into place on the miniature microscope. It looks out the front, so the microscope views in that direction. This microscope was designed to be a confocal microscope. And so in fact, there is a MEMS actuator on board here. We use structured illumination in this microscope. And the MEMS actuator can move a grating back and forth at about 100 hertz sectioning. And the whole microscope can be housed then in a device like this with a CMOS image sensor going right there. Now you'll notice that we've tilted the position of these lenses, and that was done to deal with back reflections. We wanted to image both in reflectance mode and in fluorescence mode with this microscope. And it's difficult to do good AR coding of these lenses that are printed using the grayscale photolithography. And so as a way to get rid of the back reflections, if you tilt your optical elements, you can throw the back reflection outside of your detector. And because we print the lenses, we're not limited to spherical surfaces. It's very easy to do aspherics. And so you can compensate for the fact that they're tilted by designing aspheric surfaces. So this is actually the image obtained from a microscope pointed at air before we tilted the position of those lenses. And then after we tilted them, you can see here's just the shadow of the ghost reflection that's now been tilted out of the field of view, which is shown by the red circle. And so here actually is one of the devices sitting next to a US penny to give you an idea of the scale. This is an image now. These are tumor cells that have been stained with an antibody-targeted quantum dot. And you can see these cells are about 10 microns in diameter. Remember, our Cryptosporidium pathogen is 1 micron in diameter. Mode, and this is with our optical sectioning mode. You can see we can get rid of some of the out-of-focus light. And this is with nothing in the background for reference. So we took this technology now, and we're back to Cryptosporidium. So here's our 1 micron Cryptosporidium that we've imaged with our laser scanning confocal. Here it is targeted with the quantum dot. Here it is with a wide field traditional fluorescence microscope, 40x illumination. And finally, here it is imaged with the miniature microscope. And you can see the individual pathogens, but you don't quite have the same spatial resolution yet that you have with the laser scanning confocal. Of course, the cost is about 5 orders of magnitude less between the 2 imaging systems. And so one of the things that we're doing now is exploring, are we able to sufficiently quantify the presence of labeled pathogen using this approach? But in the meantime, in our lab, we began developing in parallel the nucleic acid targeting approach, and we're actually getting quite nice results with that, and I think this will really become the focus for our lab with this technology. So remember what we're doing is we have our 2 types of gold nanoparticles that have the complementary oligonucleotides to a target sequence in the pathogen, and if that target sequence is present, then we're going to cross-link many of those nanoparticles together, and we should see the shift in the plasmon resonance. So for Cryptosporidium, if you start with the stool specimen, of course all of the nucleic acid associated with the Cryptosporidium is inside the oocyst. So you have to find a way to get it out. And you don't want that to be something that's very complicated. And it turns out with Cryptosporidium that if you just boil the pathogen, you actually lyse it, you release the DNA and the RNA, and you kill all of the nucleases that would tend to digest them. So it's a very simple way to go about doing that. We chose as our target the heat shock protein, and one of the advantages of choosing the heat shock protein, of course there's only going to be 2 copies of the DNA for that in each pathogen, but if we can look at the messenger RNA, as we heat the sample, we're going to increase the expression of the heat shock protein. And so if you heat your sample, then boil it, that's a way to amplify, a very simple way to amplify the amount of the pathogen nucleic acid and to liberate it so that you don't have to do any sort of complicated sample prep. So what we've done now is we've just taken the heat shock protein DNA, and we've taken our gold nanoparticles in solution, and we've added varying amounts of the target heat shock protein DNA. And so what I show here, now we've taken 1 microliter of that and we've spotted it onto a TLC plate. And so if there's no target present, this is what it looks like. Now if we add 10 attomolar of target, 100 attomolar, femtomolar, 10 femtomolar, and 100 femtomolar, you can just see the color change. It goes from pink to purple at the 100 femtomolar level. And so there we have about 60 billion targets. And we're capable in this test, just visually by eye, of looking at 60 billion targets. If instead of spotting it on a TLC plate, we spot it on a glass slide, and then we look at it under total internal reflectance illumination, what we see is in the absence of target, it looks green. Here it's green, 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 and it just begins to turn orange here between 1 and 10 femtomolar. That gives us the sensitivity to look at about 600 million targets. But if instead of doing the TIR imaging, we do reflectance spectroscopy, here what we have is no target present in blue, and then increasing amounts of target all the way out here to the brown. And so you can see in the absence of target, they appear green right around 550. In the presence of target, they appear orange right around here at 680. And we're actually sensitive down to the 1 attomolar level. So we've got 600,000 targets present. And so by doing the miniature spectroscopy, you can see go from singles to these aggregates, and we have the potential not only to detect yes, no, is it present, but also to say something semi-quantitative about the amount of target that is present. And so what we're working on doing now is to, instead of doing the miniature microscopy, use that same microfabrication technique to do miniature spectroscopy. And we can replace now the array of slits that we were using to do the confocal imaging with just a simple diffraction grating, and it doesn't have to move. We're also interested in looking at human papilloma virus detection. So HPV is the major cause of cervical cancer, which is a huge problem in developing countries. There are worldwide more than 500,000 cases of cervical cancer. More than 80% of them occur in developing countries. The mortality is very high. More than 280,000 women die every year as a result of cervical cancer. In fact, it's the second leading cause of cancer death among women worldwide. This is just a map that illustrates the global burden of cervical cancer. Red indicates regions where the mortality is highest from cervical cancer. So when an HPV infection is present, it causes the transformation of the epithelial cells that leads to the precancerous lesions that we talked about yesterday. And that transformation actually is initiated by the infection with the human papilloma virus. It's a very, very common sexually transmitted disease. In most cases, it's asymptomatic, and it's just cleared naturally by the immune system. Incidence rates in college-age women in the US have been estimated at more than 50%. And most women never know they have it. It's just naturally cleared by their immune system. But in some women, the infection persists, and in particular, if the infection persists past the age of 30, then there's a much higher likelihood that she will develop precancerous lesions and cervical cancer. There are about 70 different types of the HPV virus, and a subset of them are most commonly linked to the development of cancer. HPV 16 and 18 in the US are the most common causes of cervical cancer. And so we wanted to explore whether we could use a similar technology to look at the detection of HPV DNA. And so using the same technique now, we've got our gold nanoparticles that are designed to be complementary to two adjacent nucleic acid sequences associated with HPV. And what we've done is we chose one that was complementary to HPV 16, one that was complementary to HPV 18, and one that was just randomized. It was just a generic probe. And so what I show here is the TLC spot data. Here I've got different probes conjugated to my gold nanoparticles, the generic probe, the HPV 16, and the HPV 18 probe. And here I've got either no target present, I've got the complementary target to the generic probe, or the HPV 16 or the HPV 18 target. Because in this case, it's very important to be able to discriminate between the various subtypes of the HPV. And you can see that we only get the reaction when we've got the probe that is complementary to the target. So here's the generic probe, here's the cross between the 16 probe, and here's the cross between the 18 probe. And we don't get any cross-reactivity between the 16 and the 18 probe, which is very important. And you can see that either by the TLC plate or by the total internal reflectance imaging. It's not showing up very well on the screen here. It looks better on the laptop screen. You can see the orange color across the diagonal here on the total internal reflectance imaging. The final example that we're interested in our lab is looking at malaria. And this is an area where I don't have any data to show you yet because we're just developing the collaborations to begin this project. Malaria is a parasite that's transmitted by the Anopheles mosquito. It's endemic in many tropical regions of the world. And currently, if you look at the way that malaria is detected, the gold standard is microscopic examination. There are both immunofluorescence methods and other non-specific fluorescence methods. PCR is the most sensitive diagnostic test available, but very expensive. And there are some rapid diagnostic tests that are available. And typically, we quantify the sensitivity of those tests to the number of parasites per microliter of blood that they are capable of detecting. So you can see PCR can detect as few as 5 parasites per microliter, whereas the microscopy and the rapid diagnostic tests are about 2 orders of magnitude less sensitive than the PCR. And so if we take a look at the detection limit that we currently have using the oligonucleotide targeted gold, if we're doing the TLC spots with the visual readout, we can detect about 6 times 10 to the 10 molecules is our limit of detection. We have to have this or more. With the total internal reflection doing the CCD-based imaging, we're sensitive by about 2 additional orders of magnitude. And if we do spectroscopy, we gain another about 3 orders of magnitude of sensitivity. So if you look at the targets that we're interested in looking at, if you look at Cryptosporidium, malaria, and HPV, these are the clinically needed detection limits that you'll find in the literature. So with Cryptosporidium, it's about 100 oocysts per mil, malaria, 100 parasites per microliter, HPV on a cytobrush sample, about 40 million viral copies. So if you translate this into the number of molecules that would be present in a reasonable amount of sample, in the case of cryptomalaria, we picked samples that were a milliliter. Then you can see that we can match these numbers up to these numbers. And with Cryptosporidium, if we're looking at the RNA, we've only got about 10 to the 5th molecules available. And that's just beneath where we are with the TIR and the spectroscopy right now. Malaria, similar amount. And with the HPV, actually, there's many, many copies of the target available. It's in fact, a very conservative estimate. So you might even be able to do the TLC spots with the HPV. So we're really running right up into our current detection limit. One of the things that we're exploring is whether we might be able to do some amplification of our target sequence present. So we're looking for a nucleic acid. One of the reasons that PCR is so sensitive is that they amplify the amount of target sequence available using the polymerase chain reaction. So we've just started a new project where we're putting the forward primer that would be used in a PCR reaction onto the surface of a magnetic microparticle. So then you can use just a bar magnet. You can pull your target nucleic acid sequence out of the rest of your sample, and then you could add the very inexpensive components for the PCR reaction, amplify your target on the surface of this magnetic microparticle, and then come in and do your detection using your optically active nucleic acid targeted probe. So we're doing this really as a backup in case we're not able to get the sensitivity down to the point where we need it to be. So I'd be very interested in getting your feedback on this. As I said, it's a very new area for us and an area where we're very interested in finding new collaborators. So let me stop there, and I'd be happy to take any questions.
Questions?
Part of the talk where you put in the gold particles, and then you see the shift in the. But you still need some proteins to attach to the.
So the nucleic acids are what are aggregating the gold nanoparticles.
So you just put the gold particles and check the color, and you check the aggregation.
So the target that you're looking for induces the aggregation.
But that doesn't depend on the concentration of,
so
how that goes,
Yeah, one of the things that we're looking at is how do you optimize the ratio of the concentration of your target to your gold nanoparticle, because that does have a very big effect on your ultimate sensitivity. And so we're doing a series of studies where we're varying both things to look at what is the optimal region for sensitivity. And it may be that you need to design microfluidic chambers where you've got several different starting concentrations of the gold in order to, because you don't know, of course, what's the starting concentration of your target, to sort of bracket that. One of the things that I forgot to mention is that we can adjust the salt concentration of the solution, and once we get the binding, if we go to high salt concentrations, we can make them unbind. And so you do have ways to sort of recycle your reagents. So I worry less about ultimately the cost of the reagents in this case.
In the case of the HPV, how you collect the sample? Is a blood sample or
it's
is
a cytobrush, so you just scrape some epithelial cells off.
It comes from the lesion itself?
Yes.
Or that's very interesting work in this diagnostic type of thing.
Thank you very much. This was a very nice talk, very, very exciting one. But having worked with the field patients many years ago in Brazil regions here in the interior of Brazil, I found that we can separate the diagnostic in two steps. One is that you have to detect that they have a molecule in the parasite, some way to detect the molecule in the parasite, and the other one is to have all the equipment to detect that procedure. If I understood correctly, you're doing a great job of making the detection part cheaper and more available and more feasible for rural areas. But you're still bound to detecting organic molecules in the parasite. So either you use antigens or you use DNA target, which is essentially what everybody else is doing. So you have to overcome the problem of like temperature sensitivity and sensitivity of the test, like you showed in the end, that you are going back to PCR reactions.
Yeah. So one of the nice things about the nucleic acid targeting is that it's much less temperature sensitive than doing the antibody targeting, which is one of the reasons that we're really focusing our efforts on the nucleic acid detection. And in the case of Cryptosporidium, because we're targeting the heat shock protein, there are very simple ways that we can basically lyse the oocyst and get access to the genomic material. That is going to have to be worked out, I think, pathogen by pathogen. I think, and I don't mean to trivialize that, because I realize that there is a significant challenge associated with that. I think the advantage that we see for the nucleic acid-based approach is that once you sort of work out the targeting detection side, it's relatively straightforward then, because the PCR primers and good target sites they're well established for many of these pathogens of interest. But doing the sample preparation, it's a big challenge, and we haven't begun to address it yet.
I understand that it's a very recent work, and you have already done a lot of things there. But have you? I didn't notice in your experiments if you have tested biological samples, which have human DNA, human protein, blood serum, and all that.
Our next experiment with the Cryptosporidium will be to take stool specimens from normal volunteers and spike them with known amounts of the crypto to see, in the presence of all the stuff that would be present, are we still, what is the interference that we get? So,
well, if you get up to the same levels that we get today, would be very good, because going to the field work, having to carry your own microscope, centrifuge, etc. If you can just carry a pen, would be wonderful. Even if the detection level is the same, so it would be wonderful work. Congratulations.
In your nanoparticle, you add the DNTPs, or you have this nanoparticle ready to use, or you have to prepare to design these for specific combinations, or?
So the conjugation methods for putting the oligos on the gold are the same no matter what the target sequence that you're interested in. So we've got a generic way of conjugating it to the gold, and it's very stable. So you do need to identify what's the target sequence of interest. But again, we've just been going back to the PCR literature and using that to guide us in our target selection. Once you do that and you synthesize the oligo, all of the rest of the conjugation is the same.
Any more questions? So let's thank Dr. Kortum again.